Perfect. Welcome, everyone. Thank you, Dr. David Bauer. I'm really excited for today's Q&A session. We're going to start with a quick presentation about a really exciting and important, very necessary project that the Congress of Neurological Surgeons, their working group for guidelines, is working on. And I know everyone that's coming on today is really, really interested in hearing a bit more about this. But first, I always start these by having the expert kind of introduce themselves, explain why they've gotten involved in Chiari and syringomyelia related disorders. And then again, we're going to have a presentation, so you can start that. And then afterward, we can do a Q&A session. So, but first, just introduce yourself a little bit, maybe explain how you got started and why this project you're about to update us on is so important.
Oh, sure. No, Caitlin, thank you so much. And it's a pleasure to give a talk today on something that's sort of near and dear to my heart, which are really coming up with evidence-based practice guidelines for Chiari. And just a little bit about myself. So I trained at Johns Hopkins and then was at University of Michigan Medical School, where I really got into pediatric neurosurgery with a wonderful mentor, Dr. Corinne Marasco, who also takes care of patients with Chiari. And I was fortunate to train at University of Alabama at Birmingham, where I was mentored by Dr. Oakes, and he is another Chiari expert, and I learned a tremendous amount from him. And he's even written a very nice comprehensive textbook, I think the only one on Chiari. And then I was at Seattle Children's Hospital with Rich Ellenbogen, Dr. Ellenbogen, another a person who's very thoughtful about taking care of patients with Chiari. And then I was at Dartmouth Hitchcock Medical Center in New Hampshire. I then went back to school and got an MPH at Dartmouth while I was practicing, which really helped me to better understand evidence-based practices for the creation of guidelines. And I'll go into that in a little bit more detail later. But just about myself, I'm married. I have a couple daughters. I enjoy cooking, travel, biking, and I was so fortunate to come to Texas Children's Hospital really just last year. And I focus on taking care of patients with Chiari, and I'm very passionate about really better understanding Chiari and related problems and how to best take care of people. And so that's sort of a nice segue into what we're going to talk about today, and I'll start with the background. So guidelines for Chiari malformation. Why make guidelines? Well, it's a process started through the Congress of Neurological Surgeons, which is really our sort of a parent sort of national organization for neurosurgeons, and they represent all neurosurgeons. And they've the CNS has really been thoughtful about evidence-based guidelines. So they want to basically compile all the best evidence on a topic together into one document that could then be helpful for other neurosurgeons who take care of patients with these problems. And the reason it's helpful is that you have a team of experts who have used rigorous methodology to go through different published studies on a topic, and then they look to make sure that the end results of the studies are unbiased. And that's very important because in the medical literature, there can be published studies where there's some sort of bias to the study that makes the results invalid or not true. And really, when we're making these guidelines, we really want to give the best advice we can possible. And this is very different than expert opinion, where expert opinion is a group of surgeons meeting and then discussing what's the best way to take care of patients based on their experience, and then and then making a report or giving advice. And this can be helpful, but if it hasn't been rigorously studied, then it may not be the true answer. And so we use published medical evidence, and the main downside to these guidelines really is that we can only answer topics that have previously been studied in the medical literature. And this is important for you to understand that we may want to think about the relationship of Chiari with something else, but if that hasn't been studied and published, we can't discuss it in these guidelines. And so it's a big process, and you can see these steps. Really, you have to nominate a topic, and then we have to have a task force. And so we look across the country for other experts. We develop questions in a certain way, and then we submit topics. We develop a literature search strategy because we want to be able to obtain all of the literature on a topic. And then we do the literature search, and then we look at the results and we screen them article by article and read every article on a topic. We look at the evidence and we analyze it. We grade the evidence, meaning that we see if we have high quality evidence or low quality evidence, and then we have a grading system for that. And then we develop recommendations based on the evidence, and then we write the guidelines. We develop a sort of a consensus opinion among the group, and we have peer review, which means that other neurosurgeons who weren't part of the process review it to make sure that they believe the process was done correctly, and then it's endorsed and then published, and then disseminated, and then we do reviews and updates over time. And so it's sort of a living process. And so just in a little bit more detail, the literature search is done with a specific format called PICO. And these questions, it means, it's an acronym, it means Patient Intervention Comparison Outcome. And so we have to sort of write the questions in that format, thinking about what type of patient, maybe a patient who was newly diagnosed with Chiari 1 malformation, what type of intervention, and maybe that's a posterior fossa decompression with Duroplasty, and then what do we compare it to, and then what kind of outcome is important, sort of benefit. We did an extensive search. It's carried out by medical librarians through multiple databases to make sure that we don't miss any articles that are published, which is very important. And then these abstracts were reviewed by our team of experts, and then we selected abstracts that we thought fit the criteria, and then we did full text reviews where we read full text of articles, and then grade the level of evidence. And so when you talk about something, let's say Chiari, we want to have inclusion and exclusion criteria. And this is a good and a bad sort of point for these types of guidelines. And so we want to be so strict in sort of our evaluation that we can only look at certain very specific things. And so for our study for guidelines in Chiari, we're looking at all ages of patients. We're only looking at the English literature. We aren't evaluating other types of Chiari, so Chiari 0, Chiari 1, Chiari, we're only looking at Chiari 0, Chiari 1, and Chiari 1.5 because we believe these can be grouped together, but we're excluding other Chiari and mixed populations of patients, any non-human studies, any case reports of less than 5 patients, because we believe that we need to have at least a series of patients in a report to think that the evidence is valid, and then editorials or letters to the editor. And so we'll move on to risk of bias assessment. So when we look at evidence and we sort of grade the quality of evidence. We can look at randomized controlled trials or other types of trials. In a randomized controlled trial is a very specific and rigorous type of trial where patients are randomized to one group or another. And you can imagine, for instance, a study where patients with Chiari were randomized to a posterior fossa decompression versus a posterior fossa decompression with Duroplasty. And then you look at a specific outcome. And so you can have bias even in a randomized controlled trial. And so these questions that we ask and specifically look for in an article might be the sequence generation. So was the allocation between the two different groups randomly generated? Was it concealed, meaning that do people know which group they're in, or blinded? Is there incomplete reporting of data? For instance, what if a researcher published a study but didn't give all of the data because all of the data didn't sort of coincide with the result that the researcher wanted? So there's a risk of bias with that. And that's also related to selective reporting of outcomes. And it's very well known that studies that find a result, meaning that something's better than something else, are often published. However, studies that do not find a result often are not published. And that is often just as important. So for instance, if doing posterior fossa decompression was equivocal, was just the same as doing the decompression in Duroplasty, and someone may say, well, this isn't an exciting result, and let's not publish it. And then when we do our literature search, we wouldn't see that article, and we wouldn't be able to use that as data for our guidelines. So the next part, so we've done our literature search, we've evaluated the evidence, and then we've graded the evidence. We're in that process, and so then you have to link the evidence to your recommendations. And in this process, it really involves the designation of a specific relationship between the strength of evidence and the strength of recommendation. So this is a good example for therapeutic studies. So the evidence is classified into that which is derived from the strongest clinical studies. And so the best clinical studies, they're called well-designed randomized controlled trials. And so we label that as class 1 evidence. And so class 1 evidence, if you have a randomized controlled trial, then the class 1 evidence is used to support a strong recommendation, or a level 1 or A recommendation, indicating that there's a high degree of clinical certainty that these results are real. Then you can move on to a non-randomized cohort study, which is a different type of study looking at one group versus another, that is not randomized, or flawed randomized controlled trials. And these give you class 2 evidence, which then gives you a level 2 or level B recommendation. And then you have other sources of information, such as observational studies or case series or expert opinion. And so these would be reports where one neurosurgeon might write an editorial or an article on his or her thoughts on Chiari. And or you'd have a series of 5 or 10 patients that were published on a patient with Chiari. And so this is thought of as being class 3 evidence, and any recommendations are sort of uncertain based on this. And that's because these are really just an anecdotal experience that someone has, and it hasn't been rigorously studied, it hasn't been compared against something else. And so there's a high chance, a reasonable chance, that whatever is published may not be true. And so the purpose of the guidelines is to only publish results that we really know to be true. So here's a different way of looking at things. And so this is sort of a table. And you can see on the left the different types of studies, the level 1, 2, 3, and 4. And we look at different types of studies that we're doing for guidelines. So therapeutic studies, prognostic studies, diagnostic studies, or also the economic or decision analysis. And so for therapeutic studies, so this would be what type of surgery is better for a patient with Chiari malformation. Again, the level 1 evidence is the high quality randomized controlled trials. The level 2 evidence are the lesser quality randomized controlled trials or prospective comparative studies. And then level 3 evidence, they're case control studies or retrospective comparative studies. And then level 4 evidence, case series. And case series, again, would be a series of patients that a surgeon may have that are basically described in an article. And just to link the level of evidence to the grades of recommendations, again, our grades of recommendation for A, B, and C. Grade A would be it's a recommended, B suggested, and C is an option. And so looking at the level of evidence that you need to support that type of recommendation. So a high grade of a recommendation, you really need 2 or more high level studies to support that type of recommendation. For a grade B recommendation, you need maybe 1 high level study or 2 sort of lower level studies. And for a grade C recommendation, maybe a level 1, level 2, or level 3 study, but with some other supporting level 4 studies. And so in effect, again, this is a way for us to make high quality guidelines that that are true, that are unbiased, that give the best quality data and suggestions to neurosurgeons on a certain topic. The downside to this is that we are so rigorous with with what we're doing that it could leave questions unanswered because there's not enough evidence, not enough articles written on the topics to be able to answer those questions. So when we develop a recommendation, so the critical issue of the recommendation is that it reflects the strength of the level of evidence upon which it's based. And we really want to minimize the bias that could be interpreted in the studies. And so moving on to Chiari. So our Chiari guidelines have 3 main questions. I'm the leader of the working group and help to develop these questions with the group. And in part, my job was developing questions that we could answer based on the medical evidence. So I'm have a particular interest in complex Chiari malformation. I'll go into that in a little bit more detail. However, unfortunately, there's really just not a lot of medical evidence that's available on complex Chiari, and most of the evidence that we have basically evaluates patients with typical Chiari 1 malformation. And so that's where all of these questions are based. And once we do guidelines for Chiari malformation, then maybe we will be at a point where we'll have enough medical evidence to tackle complex Chiari, which I think would be very beneficial to patients with complex Chiari. But for our guidelines, we've broken it up into 3 different parts. You can see over on the left. The first is diagnosis of Chiari, and so we'll look at imaging to evaluate for hydrocephalus, syrinx, tethered cord, advanced imaging for Chiari, and dynamic imaging, and is it helpful and should it be done? And then we'll evaluate treatment of Chiari and discuss what symptoms are most likely to improve. Should anyone ever have prophylactic surgery? This is an important question. I see kids all the time who have had a concussion and then have a head CT a CAT scan of the head that diagnoses Chiari, and I see worried families who worry about their child and wonder, should we do surgery? Should we watch? Should we obtain an MRI? And so we'll try to address that question. Should I have any activity restrictions if I have Chiari malformation? Should we obtain a swallow study or a sleep study? Should patients with Chiari obtain these additional studies to better evaluate the preoperative symptoms? And then should my family get screened? Is Chiari hereditary? And so we'll answer those questions for chapter 2. And then for the third part, we have a few additional questions. One is looking at surgical technique. And so, as you know, for Chiari malformation, the first part is really evaluating the craniocervical junction, evaluating Chiari, looking for a syrinx, a fluid collection in the spinal cord, getting any additional studies. And so then the second part, once we've made a diagnosis and we've discovered all of the different symptoms someone might have, then it's what type of surgery is best. So looking at the posterior fossa decompression versus posterior fossa decompression and Duroplasty question, there are other adjuncts or technical parts to surgery that I think more and more families are savvy about. I know personally for my families, I discuss all of these things because my job, I feel, is to bring my families and patients up to speed on the latest medical evidence. And cerebellar tonsil reduction, is this important? Should this be done? Is it harmful? Is it beneficial? What's the role of intraoperative monitoring? Is it necessary? When will the syrinx improve and get better? When would we expect that? And is long-term follow-up care needed? If I have Chiari malformation, do I need follow-up for years and years? If I'm doing well, do I only follow up if needed? And so we'll try to answer all of these questions with the guidelines. I can say 100% that we have a stellar team. I'm so fortunate to have so many wonderful people who are with me on the working group from just amazing children's hospitals and from across the country. And in addition, we asked Bobby Jones, CSF, to be a part of our process. And so Dorothy and Caitlin are also members of the group, and we're so fortunate to have them as part of our group because, as you know, really the questions that we're asking, we want to be able to answer them, but we also want them to matter to families and patients, to be patient-centered. And so it's been so helpful. So that's my talk on the guidelines. I hope it wasn't too in depth. I could probably talk for hours on the nuances of guidelines methodology, but in short, I think I was able to get through the important parts. And I think importantly for patients, it's important to understand that the guidelines, I think they will be worthwhile. I think that we will need additional guidelines as more evidence comes out, and ultimately we want the guidelines to be true, to be based on very high level evidence. And then the nice thing is at the end of the process, we can see what questions have low level evidence, and that might spark groups to then better study Chiari to obtain the higher quality level of evidence, which I think ultimately is really what we need to do. And other groups such as the Park Reeves group and Dr. Limbrick at WashU really have been doing a wonderful job in really thinking critically about Chiari. So my clinical interest really, and I see many patients at Texas Children's Hospital, is complex Chiari. And I think that patients with complex Chiari may be not applicable to these guidelines. However, I've had significant experience taking care of patients, and I really enjoy taking care of patients with craniovertebral junction anomalies and different congenital fusions of the cervical spine, basilar invagination, syringomalia, hydrocephalus, and some of the sort of buzzwords, the things that I use to evaluate my patients include a clival axial angle, a PVC2, and basilar invagination. And I see many patients with other comorbidities, which is really just another name for other sort of problems that they have besides Chiari that can include clipophil, skeletal dysplasias like achondroplasia or chondrodysplasia punctata or craniosynostosis, connective tissue disorders such as Loeys Dietz or hypermobile Ehlers-Danlos. And just for people who are interested, these are the angles, the measurements that that I think matter. The clival axial angle, really looking at the clivus, and so just to give you a better idea, this is the skull and the interior front part of the base of the skull, and looking at the angle between the skull and the spine, and then looking for basilar invagination, so where part of the spine comes into the space of the skull, or looking for what we call ventral compression, where part of the odontoid, the bone of the cervical spine, kind of goes backwards and then pushes on the brainstem and may cause some of the symptoms from Chiari. So in summary, the CNS, Congress of Neurological Surgeons, is producing guidelines for the diagnosis and treatment of Chiari-1 malformation. We're going through an extremely rigorous process. Many smart people combing the literature with a fine-tooth comb to ensure there's minimal bias in the results. The guidelines can only cover topics that have significant publications in the medical literature, so this is really the downside. But the purpose is to help educate physicians on the current best practices based on the medical literature. And I'm certain once we've finished the process and we have a publication, then this will be sort of disseminated with Bobby Jones CSF. And so I think it'll also be a good reference for families as well. So that's the end of my talk. And Caitlin, thanks again for inviting me to speak. And I'd be super happy to have any questions.
Absolutely. So again, everyone, you can just use the chat function if you have questions as we go. Um, there was a question that I wanted to ask just specifically about the guidelines. So I know this is going to come up. Are the guidelines only going to be applicable in neurosurgery, or will this be something that can also be brought to other disciplines? I know incorrect positioning when a patient gets an MRI can actually drastically change whether or not they have a Chiari, which I'll get to in a second. So is this something that will be applicable across disciplines?
So that's a great question. So I think so. I mean, guidelines. These are specific for neurosurgeons. However, oftentimes neurosurgeons are ordering these studies. Once a patient's identified. I do know what you're talking about as far as the positioning in the MRI scanner, and so I routinely get flexion and extension MRIs on patients, and I think that's a very helpful type of study. And I do that occasionally on CTs as well. And looking at the cranial vertebral junction and looking for abnormal joints and movement and things like that. You are exactly right. So I think it's a work in progress. I think we need more data on topics like that.
Yeah. So I guess I'll jump to the other question then because it's kind of related. We get this question a lot. So what is that 5 mm rule? And so if someone has a 5 mm Chiari and then a month later, or rather like a year or so later, they have a 6 mm Chiari, people will get nervous. They'll say, oh my God, it's getting worse. So what is that? And why does that maybe happen? And maybe you can explain.
No, that's a great question. So, I think there's a few things. So, like you said, the positioning in an MRI scanner could, if a little bit of flexion, a little bit of extension, I mean, that could definitely probably change things by a millimeter or so. I don't know of a good study looking at that, but I think that's, possible. Also, just the gantry angle. So what that means is when you do an MRI, the MRI tech has to line up how they're going to sort of take those slices. If you've seen the slices, you know you basically get a bunch of slices, and so if that angle is a little bit one way or the other, then it could make the Chiari look 1 millimeter longer or shorter. So I guess I don't pay a lot of attention to that. I did write a study when I was at Dartmouth looking at patients, kids over time who had an MRI every year, diagnosed with Chiari but didn't have symptoms, and we did notice that there was a little bit of variability on future scans as far as the position of the cerebellar tonsils. And gosh, could it be that the children were growing up? Could it be that they were positioned a little bit differently in the scanner each year? It's hard to tell. So those are great things to think about. But I focus more on symptoms when I take care of my patients.
Perfect. So I guess I'm gonna get to this one just before I get to sort of like longer follow-up stuff. But you kind of hinted at it in the fact that you are interested in complex Chiari and all the imaging. But what are your thoughts on upright or cine MRI in Chiari patients? Do you find it helpful clinically now, even before we finish this guidelines process?
No, great question. So I think the cine MRI is it can be helpful, but I think that there's it's a type of MRI that sometimes is operator dependent. And so that's something for everyone to sort of understand. And this is the same thing with upright MRI, that it's those are typically a lower power of a magnet. So they're measured in Tesla, and the 1.5 Tesla MRI is okay. A 3 Tesla MRI really gives better detail, and so that's the only downside for an upright MRI, that it's not as good of a resolution. And the same thing with cine, that it's a little bit operator dependent, meaning the tech that is doing the MRI and the processing that the computer has. And so I find that it can be helpful, but it's because of that variability, it can be difficult, especially if I'm looking at a study that's done outside of my system.
Okay. So a question came in before we got on today, and it's a really good one. So Chiari was found in a young toddler. I have to assume they got an MRI for another reason, but the doctors don't believe the toddler to have symptoms related to the Chiari right now. So is it likely that at some point in life that that child is going to need surgery, or is it possible that they'll be fine for the rest of their life?
No, Kaylin, that's a great question, and I'd worried the same thing, for my kids. So the data, so there are a couple studies that look at patients diagnosed with Chiari who are asymptomatic, not symptomatic, don't have symptoms, and in both studies, it's about a 2 to 3% chance that over the next 5 to 10 years, a child would develop symptoms and need surgery. And so that was based on either developing a syrinx or developing headaches, that were related to Chiari. So and both studies were pretty good, but not perfect. And so um, so I do think there's a chance, if you're a child and you're not symptomatic, that you could develop symptoms. I wouldn't recommend prophylactic surgery, but I typically have very close follow-up from my patients afterwards, just to make sure. And I think education is the other part, and this is where you guys come in. Where if you know that you have Chiari, if you don't know the symptoms and haven't been educated and are up to date, then it's hard to take care of yourself. So
Yeah.
great
I'm
question.
sorry. By the way, my dog was just eating my clothes, so I had to just grab that.
Oh
But
no.
okay, so sort of related to that, if that child is symptom free, is it possible that a syrinx could form and that child would still be asymptomatic? And if so, is that something that would need operation, or is okay to watch? I'm not sure.
Yeah, no, that's a great question. You know, we don't have great data on this, but I can give you my anecdotal experience, and it is possible to develop a syrinx if you have Chiari and don't have a syrinx, and so I've definitely seen that before. But typically, kids will develop symptoms, and really the question is, what's a symptom? And so, you know, it could be scoliosis, which, you know, isn't a headache, isn't, you know, weakness, but is curvature of the spine. And so I think by and large, if a child has Chiari, no symptoms, and then develops a syrinx, that at some point a symptom would develop. And I think part of the question is, would you recognize it? And so that's where, again, I think the education part is so important.
So in that vein, a question had come in the chat about that. So what would you consider symptomatic, or symptoms to be looking out for? And I guess it's going to be different for infants, children, teens, or an adult. What would you be looking for in each of those subgroups?
No, no. So you're exactly right. And uh, the so just thinking about infants and a child, an infant, you know, a 6 month old, being able to tell you that she has a headache. I mean, that's just not going to happen. So you have to basically go by how a child looks, and often in infants, if you have Chiari and a syrinx, you might have some cranial nerve or brainstem type problems. You might have swallowing problems. You might have some weakness, and then as you get older and the sutures, so the bones between or sort of the connections between the skull bones start to fuse, then you may start having different symptoms. Ultimately, the classic Chiari symptom is an occipital, which means the back of the head headache that or pressure sensation that happens with Valsalva. And what that means is bearing down or coughing or straining, sports related. And so that's really the classic type, but you can definitely have other brainstem type symptoms. You can have syrinx, and so you can have paresthesias, which are sort of a numbness, tingling in the arms or legs. I've seen some patients have hydrocephalus, increased pressure in the head. Um, Patients have swallowing problems, some other sort of more unique symptoms, and that's where really it gets kind of hard. And so, as a neurosurgeon thinking about what is symptomatic, really, I find that it's very important to have a really thorough history and listen to families, ask a lot of questions. When I'm not certain, the last thing I want to do is put a child through a surgery that isn't needed. And that's the hard thing about Chiari, that not everyone needs surgery. And so I'm always very willing to say, hey, come see me again in a few weeks, or we'll do a video visit, we'll check in, do a symptom diary, let's you know, get more information, and so that we can make the best decision. And so that's ultimately when I'm not quite certain, you know, just getting more information is always, in my opinion, the right answer.
A follow-up came in. So is scoliosis alone as a symptom enough to warrant surgery? And this is across all ages, so it might also be different too. But
So that's a very good question. So I guess the question is, in my mind, what does scoliosis mean? And so scoliosis is sort of a general term, but you can have severe scoliosis, or you can have just a very mild curvature. And so there are some studies looking at whether scoliosis improved after a Chiari decompression. And the literature is a little bit mixed on that, and some studies show that the scoliosis didn't really improve with the Chiari. However, there's definitely some bias in it, and who knows, maybe you just needed to catch it early. And so I think more needs to be done to study that. But I do think if you have Chiari with a syrinx, that to me is a plausible mechanism for scoliosis, and treating the Chiari and having the syrinx get better sounds like a reasonable way to prevent it from getting worse.
Another question that came in earlier, while we're sticking with kind of symptoms, is hearing loss considered a symptom of Chiari? They say the cochlear nerve is located by the cerebellum, so it seems sensible to believe Chiari could cause that since it's in that area. But I don't know how well that's been kind of talked about in the literature. Do you know?
No, that's a great question. So I don't know of really good literature on that topic. And so a lot of Chiari literature really looks at a series of patients, 500 patients that I treated with Chiari, and often focusing on headaches. The problem is that many of these studies did not explicitly ask about hearing. And so it's very possible that some of the patients had problems hearing and maybe they got better, but it was maybe a symptom that was missed because people didn't ask. And so that's where you can have bias that can come into these studies. That really, if you want a well-done study, you have to, at the beginning, say, okay, I'm going to ask about all of these things. And so then you don't miss something. So
Um,
I wish I had better data.
yeah. A really good question came in. This is perfect for you. I'm surprised that there are blinded studies in neurosurgery. So how does that work? Do patients not know the kind of surgery that they're going to have in these studies? And is that something that's been going on? I have something that I would say, but I want to see what you say first.
Oh, no, I'd love your thoughts too, Caitlin. So, regarding blinded studies, they are not common for surgery. That they're not common because ethically, if I do make an incision and then let's say I just make the incision and don't do the actual surgery, and then I just close the incision, that just doesn't sit well with me, and so. And there are rigorous IRBs, or these institutional review boards, that wouldn't allow that to happen. That being said, there are some studies that will implant a device, let's say a stimulator, and then they will have the stimulator off at first, and then they will turn it on later. And then some patients, it'll be on at first and off later. And so all the patients know that they're going to get the stimulator, they just don't know if it'll be on or off, and then you can evaluate. So those are really the only types of studies I know of for neurosurgery. What were your thoughts on that?
So my only thing would be the the one RCT that Dr. Limbrick is doing, which actually the blinding was done by sight. So the way it worked
Yeah,
is you would go to a specific site and they were doing one or the other surgery, and the patient wasn't blinded to it, but the surgeon sort of was by kind of
the,
making it be
the,
that. Yeah.
no, you're exactly right. Yeah, so I'm part of that study. I'm
Oh yeah.
Yeah, so the posterior fossa decompression versus Duroplasty. And so
Yeah.
um, doing the study in the consent, families were consented for Chiari surgery with or without Duroplasty, but the family didn't know what was going to happen. And so then they said, okay, we want to be part of the study. And then the surgeon would say, okay, you're part of the Duroplasty group. And so so it was sort of the family sort of made the decision one way or the other, and then sort of went with that. But they knew it eyes wide open. So
Right. Yeah.
uh, it's hard because, but in some sense, that's the only way we can get good data. But on the flip side, and as a father, for my child, that worries me. And so it's hard. So I think it's just being thoughtful and having families be educated on all parts of it, and it's a choice if you want to be part of it or not.
Yeah. Yeah. So I'm really
Yeah.
glad that question came in because that was a really good one. Um,
Oh yeah. Yeah.
so I guess sort of talking about surgery, this is going to come up in the guidelines process anyway, but what is a good decompression, quote unquote? Do you generally know if there's enough space created? What do you rely on to kind of figure out whether or not the surgery worked, I guess is the word.
Um, well, so I think a surgery works if symptoms get better. And so, so if someone has symptoms, I think they're related to Chiari. We do the surgery, no matter what surgery you do. You do a Duroplasty, you don't, you do a fusion, you don't, but the ultimately is making a patient better. And so, as far as what do you need to do to get to that result, that is a harder question. So, no one has looked at different ways of doing the decompression and really published on sort of what landmarks do you use to adequately remove enough bone without removing too much bone, which can also be a problem. So I think it's in part maybe how people are trained, and I do think that for society, for making society better, that's probably a project that I'm going to work on at some point because first I need to evaluate among surgeons. So what is your practice and what are your landmarks, and then after that study it, and see. And maybe some of the Parks Reeves data, could be used to evaluate that. But that's a very good question. Yeah, and
So
that's why I think, for families, uh, if you are taken care of by someone who takes care of many patients and patients are getting better, um, then that probably means it's an adequate surgery or decompression.
yeah. I'm going to go back to the last question because there was a follow-up that I feel like is important to address, and I feel bad that I'm making you be the one to do it. But
Oh, I'm
so
happy to.
so the blinding that we described in the surgery, oh my gosh, the RCT. Um,
Yeah.
there was a question: would that lead the neurosurgeon to not making the best individual decision for the patient? And I think you probably, as a father, would be able to respond to this. But go ahead.
Yeah, no. So this is hard, and so um, being a site investigator for the Chiari study, you had to basically say that you had equipoise, which is a term that says you really don't know whether the Duroplasty was going to be beneficial or not, and so. So every surgeon really had his or her opinion of whether Duroplasty is beneficial, and I can tell you just with my colleagues across the country, some of my colleagues always do a Duroplasty, and some rarely do a Duroplasty. And even the complication rate with Duroplasty is different from across the country, and even how it's performed is different, using a synthetic substitute, using a pericranium, which is someone's own tissue, and even how you open the dura. Is it a linear incision, a Y incision? There really is a lot of variability, and none of that's been studied. And so ethically, I think studies are okay as long as everyone involved is okay with being in the study. And so for sure, I had patients who said, I just don't want to be part of the study. Please do what you would do. And I happily did that. And I think then it was okay.
Yeah.
So
Okay.
those are great questions. It's good to
Yeah.
think about those things for sure.
Yeah, absolutely. Um, similarly, you're talking about techniques. Do you open dura, score dura, resect tonsils? So there's like you said, there's a billion things that you can do. What's your general practice, or does it depend on the patient?
It depends on the patient, and I do think that um, regular Chiari, where there are no craniovertebral junction anomalies, is a very different problem than complex Chiari, where you have basilar invagination or a clival axial angle that is more acute. I think the patients in the two different groups may need different types of surgeries to improve. And yes, I often do Duroplasty, and I like pericranium because when I ask my families, not a single family wants a synthetic substitute. When I tell them about it, and I really, and a lot of what I do is informing families completely about all the options, because I think that's important. Um, I think tonsillar reduction is very helpful, and think that some patients, they probably don't benefit from just a decompression, and require the reduction to decompress and to have enough space, which is really the ultimate goal for surgery. Um, and I see these in patients with complex Chiari. And so some patients need fusion, and I do my best not to do a fusion, but some patients, that's the only way they'll get better. And so ultimately, it's really tailoring these things to your patient. And so that's the hard part about guidelines, is that what if everyone with Chiari didn't have the same problem?
Mhm.
And if that's the case, then you can't use sort of a cookie cutter guideline to take care of everyone. And so that's why it's important to be really specific in what we're discussing and our recommendations for treatment, because it probably they aren't applicable to everyone with Chiari.
Yeah. Um, a question that came in earlier kind of talks about this. In your experience, is there a certain percentage of patients with Chiari who have EDS that will probably need a fusion, like a craniocervical fusion at some point?
No, for sure. So I've seen many patients with connective tissue disorders, and it's something I always evaluate for in clinic when I see a patient with new diagnosis of Chiari. And yeah, a fair number of patients do need craniocervical fusion, and a fair number don't. So I'd say probably more don't than do, but um, it's always something I discuss with families, ahead of time, even before a decompression. And I think it's something for families to know about ahead of time.
How, um, just in your own practice, maybe, how do you screen for those connective tissue disorders? Because I know they can be kind of hard to find, I guess.
Yeah, no. I'm fortunate. So at my hospital, there's a program for patients with connective tissue disorders, and so we have a lot of resources. But personally, so I ask if families, if a patient's double jointed, I ask them to try to bend their fingers back, and some of the criteria for diagnosis of hypermobile Ehlers-Danlos syndrome, I ask them about. And then if I'm concerned, then I send them for a referral for evaluation in our clinic.
Okay. Um,
Yeah.
a question came in again. This is more about complications. So do you notice that there are more complications if there's more than one decompression done? Um, is the rate of complications, is that any way influenced by whether or not a previous decompression was done, I guess?
Um, so great question. Complications, there's something to worry about for sure. I guess the question is, what's a complication? And is it infection? Is it bleeding? Is it a spinal fluid leak? For sure, after a decompression, sometimes you can have some scar tissue, and I don't worry so much about scar tissue that is um, below the skin but above the bone and the dura. But I worry about intradural scar tissue. And so I've taken, gosh, I see a lot of referrals from around the country, and some patients are who really have a tough problem have had either an infection or some bleeding intradural that's caused scar tissue, and then adhesions, and then blockage of the flow of spinal fluid. Really, the thing that you want to open up. You want free flow of the spinal fluid around the back of the brain, and so all of that scar tissue can really be challenging to take care of. And so that's when you do have a higher rate of complications. with additional surgery. But if the first surgery didn't have bleeding or infection inside the dura, then typically it's not difficult or hard to take care of someone for a second decompression.
Okay. What, I did have a question, excuse me, about this. I just want to find it. Oh, okay. This is kind of it. How long does it take to get better after surgery? So how long until you know whether or not symptoms are just not improving, or maybe the symptoms went away and then they came back? How do you know when to have a second decompression, when to go back in?
That's a great question. So, and there's a lot of things to think about. So, the first of all, what's a symptom? And so because there's so much overlap between Chiari and other problems, I have many patients that have migraine headaches and Chiari, and I tell my families before surgery, your migraine headaches probably won't get better. Occasionally they will, but they may not, and so the Chiari headaches will get better, and so we still need to continue, the migraine medication. So it's sort of having those types of expectations ahead of time. Was the source of the symptom misdiagnosed? Did we think that it was from Chiari, the swallowing problem, and actually it's from something else? And so I think that's a tricky part, and so that's why if I see someone being evaluated for a second surgery, I always do a thorough evaluation of my own to just think about all those things, the decision making, look at the films to make sure maybe the decompression wasn't adequate, maybe you needed a Duroplasty and a Duroplasty wasn't performed. It's well known that about 15% of patients at least need a Duroplasty, but it's just hard to tell which 15%. So there are a lot of variables for sure.
Yeah. But I guess how long does it take to feel better? So why can't I think of the word for
No,
resolving?
no,
That's not it. Healing?
no,
No.
no,
Yeah.
Yeah, no, Caitlin, that makes complete sense. So I see what you're saying. So it's variable. So often for my families, once they're through sort of the 2-week period of recovery and the pain's gone away, then the Chiari headaches are usually reliably better at that point. And so that's a certain symptom, the headache with activity. Other things like, let's say, paresthesias, tingling in arms and legs, may take a little bit longer if there's a syrinx and the syrinx hasn't resolved. The syrinx can resolve even up to a year later, so it may not change a lot at first, and it may take a while to resolve. And so some symptoms may take a bit longer. When I am worried about a patient, I'll think about some symptoms that I think reliably should get better, like headaches, and if they're better, then often the other symptoms will get better over some time. Doing a repeat surgery is really nothing to rush into, I think, for Chiari, just because of the symptom overlap. And so I'll have to say that it depends. Everyone's unique. So,
Yeah.
but it's a great question. Yeah.
Um, Similarly, how long do you generally follow a patient after a decompression? So is it very unlikely that their symptoms will come back, even if it's many, many years down the line? How long do you really realistically watch?
That's a great question. And that's something we're trying to answer with the guidelines. But ultimately, it depends on how old you are. So for the young patients, 1, 2, 3, 4 years old, I'll follow for years through skeletal maturity because the craniocervical junction can change. For older patients, 16, 17, 18, or adult patients, I think probably a few years of a follow-up is reasonable. Often I'll have a shared discussion with the family and say, hey, you're doing great. Your symptoms went away. We got an MRI 2 years after surgery and everything looks good. Do you want to see me again next year? Or do you want to see me as needed? And I can say by and large, most families say they want to see me as needed. And they'll call me if they have a problem because they know I'll get them right into clinic. And so, um, from a patient standpoint, the hard part about getting a yearly MRI is often the cost, because now more and more people have high copays and are paying, $1,500 for an MRI. And so, in my experience, I found that most people, the MRI really doesn't change unless the patient has new symptoms. And so, you can probably forego a lot of those routine MRIs, as long as someone's doing well.
Yeah, that's really good advice because I know that's a big issue. A lot of people will call up saying that they can't get an MRI because the insurance won't cover it, and I'm
Oh,
sure it
yeah.
would make people feel a lot better to know that if there's no change, they likely won't need that.
Yeah.
Oh, I see. Okay. Back to the guidelines really quickly. This question came in earlier. Will and I believe I know the answer based on your presentation, but will the guidelines for the treatment of Chiari include advice for treating Chiari in patients with EDS? And if so, what do you expect those differences in consideration of treatment to be in those patients?
Oh, no, great question. No, our guidelines, at least this iteration, won't look at EDS. I do think it's very important, and I think in part we just need more data, more studies on patients with EDS and Chiari, to give better recommendations. I look at it as sort of an iterative process, meaning that we sort of start with the low-hanging sort of easy things to answer, and then after that we'll get to the harder things.
If you had to give your own wild conjecture, do you think there would be a difference in how you would approach those patients?
Um, who are diagnosed with
EDS.
hypermobile EDS and Chiari? Oh, for sure, yeah. So I often routinely do the FlexX MRIs for most of my patients, but for those specific patients, I think it's critical. And so, yeah, for sure, I think about things a little differently.
Yeah.
It's basically just evaluating for instability in the craniocervical junction.
Um, And then I'm going to keep asking you these questions that we may or may not have answers to yet, but do you generally restrict certain physical activities? I know it comes up a lot, and just I'm curious, are some sports maybe more or less safe to engage in, depending on age?
I know, great question. For kids with Chiari malformation who have no symptoms, I don't see any reason to restrict them from any physical activity. For kids who have Chiari and they've had surgery, they've had the decompression, and then they've had dynamic imaging showing there's no instability, and they've completely healed. I think it's safe to go back to tackle football and contact sports. And at a pediatric neurosurgery meeting, I like to give this sort of anecdote. We asked that question, and half of the pediatric neurosurgeons said they would let a child go to play tackle football, and half said no. And so what does that mean to me? It means that we just don't know. But I can tell you there are no case reports or other sort of reports of a patient who has had a Chiari decompression, played contact sport, and then been hurt because of the decompression. I think it's safe, and I think physical activity is a good thing, but as long as I think ultimately a family knows that information and then can help make the best decision. Some families wouldn't let their kids play football. That's okay, it's dangerous. So it's good to do whatever's in the family's best interest.
Yeah, I was going to even say, but if about 50, half of the room is going to say yes and no to football, I think that's not even specific to Chiari. I think that's just generally speaking. So,
Yeah, for sure. So it's just it's interesting. So.
Yeah,
That's another one of my interests is variability in neurosurgery in practice, and sometimes the variability doesn't matter, and sometimes it does quite a bit. So it's good to sort of study that.
yeah, that's awesome. So uh, if if an adult has a Chiari and so does maybe an older child, and again, this is going to be touched on in the guidelines a bit, should a younger child of that person also be screened for Chiari if there are two people in that immediate family that already are known to have it?
So great question. We don't have great data on that. We do know a few things. So there are a couple reports of whole families having Chiari with the thought that it's the way the skull is configured. We do know there's a type of dog, a Cavalier King Charles Spaniel, that has a small posterior fossa sort of back of the skull, and so the dogs all get Chiari. Um, my thought is when I take care of families where multiple family members have Chiari, I'll ask. And so I had recently a family and they had a Noonan syndrome, and so the whole family had that. Everyone had Chiari. So I think there's definitely a potential. It's not in every family, but it's good to ask. And I'll always ask, oh, does your other child have these symptoms? And sometimes we need to do a screening MRI for sure. It's those are good things to think about.
Um, this is a good question. Is there ever a reason to not operate on a big syrinx?
Great question. I think it depends. I mean, what does it mean to be a big, And then do we think the syrinx is related to the Chiari? And if so, I think most neurosurgeons would say if it's related to the Chiari, that the Chiari needs to be treated because the syrinx will at some point cause injury, damage to the spinal cord and symptoms, and we don't want that to happen.
I think we've gotten this question before too, so I'm just going to ask it because a lot of people don't realize what is the treatment if it's just a syrinx. So idiopathic syrinx, what would a
Oh,
neurosurgeon do, especially if there's symptoms?
uh, so this is a great question. So idiopathic. So what does that mean? So a syrinx that we don't know what it's caused by. When I see a patient with a syrinx, sometimes you can have a dilated central canal, which is just a little bit of fluid in the spinal cord, but it's benign. It doesn't cause any problems. It won't change, and so we don't need to do anything. Occasionally, you can have a syrinx and it's caused by a tumor, and so sometimes we'll get an MRI with the contrast and evaluate for that. Sometimes it's caused by adhesions around the spinal cord. Sometimes it could be Chiari zero, where there's a blockage at the fourth ventricle, but no herniation of the cerebellar tonsils. Um, Maybe there's some sort of tethered cord. Maybe there's spinal cord herniation. There are these sort of very rare but real entities. And so usually if a syrinx is symptomatic, there's something causing a problem. And so my job is to figure out what that is and then treat that. You can put a shunt into a syrinx, but that's really not something that's needed to be done very often because usually you can find something that's causing it and you can treat that. So great question. These are challenging things to think about even for a neurosurgeon, and there can be rare things that can be causing a problem that might not be picked up easily or by everyone.
So speaking of tethered cord, um, what is your take on the occult? So it's not on imaging, but maybe there's a syrinx at the lower end of the spinal cord. How do you go about treating that? Is it just you attempt the untethering, or how do you generally approach that?
Um, this is another great question. And you're asking it because I guess there's not a lot of data, which is true. So if you have tethered cord where and what that means is the spinal cord is lower than it should be, and then it's tethered with some connective tissue to the sacrum, to the tailbone, and so sometimes it's obvious, and sometimes patients have obvious symptoms, which are back pain or leg pain or weakness or bowel or bladder incontinence, but not always. And so there are some patients that may have a small syrinx and maybe a slightly low spinal cord, but maybe don't have any symptoms. And so what do we do? I think look at every patient individually and look for symptoms. Sometimes I'll follow someone over time. Urodynamics can sometimes be helpful to evaluate for urinary problems and then figure out whether someone is having symptoms or not. And for sure, if there's a high enough level of evidence that someone's having symptoms, then I think detethering is a very reasonable thing. With any surgery, even if there's low risk, it doesn't mean no risk. And so it's always important to look at the pluses and minuses.
Yeah. I fully agree. So this is a good one, especially for a pediatric neurosurgeon. So say a child had surgery at like 8-ish years old and they're doing fine. Maybe they're coming up on 17, they still have occasional headaches, nothing serious. What's the how do you transfer care to an adult physician? Should that patient specifically see a neurosurgeon? Should they see a neurologist? Can they stick with a primary care? What's the usual process for going from pediatric to adult with minor issues that might not require surgery?
This is a challenging question across the country for even other problems, spina bifida and other problems. So there are best practice sort of standard guidelines for transition of care that many hospitals, big children's hospitals, are trying to do. I know at our hospital, I'll often follow some patients into young adulthood because I just like the continuity of care. Other places have sort of a strict cutoff for age, if you're at a children's hospital, and then other hospitals, the children's hospitals within the adult hospital. And so the pediatric neurosurgeon sees both adult and pediatric patients, and so you don't have to switch. And so, which is often nice. But I think if you were in a situation where you had to switch, then what I do is I specifically would make a phone call and connect that patient with a colleague who I felt comfortable knew about that diagnosis. And so I do that routinely for families that let's say they move to another state, and so I call my friend who I know in that state and connect them, with another pediatric neurosurgeon. So I think that's important because for a family member, something that would be hard is if your child or yourself develop symptoms, and then who do you call and who's there for you? And so it's always important to know who's there for you.
Okay, so we're getting a couple of last call questions, so I'm going to ask them.
Okay.
So this is a good one. Can tethered cord be higher than the typical L5 S1 area of the spine? Can it occur higher?
Meaning can
I think they're talking about the conus, so where the spinal cord
yeah.
ends.
Yes,
Can it be
so the
higher?
spinal cord ends. Yeah, 100%. So for tethered cord, so it's usually at the around the L2 level or below. Some people might say L1, L2, or bottom of L2. And there's some variability in that, and because everyone's a little different, right? Some people are 7 feet tall, and some people are 5 feet tall, and there's people in between. And so being fixated on sort of a hard and fast number like the 5 millimeters for Chiari may be missing the forest for the trees, in that it's really the symptoms that matter a lot. And so even at L2 can be tethered. I think in some cases, even a little bit above that, you can have a normal position conus tethered cord, although that's not common. The surgery is usually at L5, S1, just because that usually is below the level of the end of the spinal cord, the conus. So that's usually where the surgery is, just because technically it's the safe place to go.
And then this is really interesting. I feel bad you're getting all these really complicated ethical questions. So, um, if your child has a complex Chiari, but the child doesn't want to have the surgery or fusion, is it okay to wait even with debilitating symptoms? So, I mean, even just as a neurosurgeon, how do you handle, as a separate question, if the child
Yeah.
especially doesn't want to undergo surgery?
This is a very important question. So what I do is I have a frank discussion with every child on that child's level. And you talk to a 6-year-old differently than you talk to a 12-year-old or to an 18-year-old. And so I think that's very important. I think in some sense it's a family decision, and I think education, in my opinion, I've always been able to educate my families to the point where they're making a good decision for themselves. And I don't think forcing anyone into surgery is ever, the right thing to do. But if someone should also understand the repercussions of not doing surgery, what might happen, and then always have the option later of saying, oh, I made the wrong decision, let's do surgery. And so by and large, when someone's been symptomatic and I talk to them about the repercussions, and maybe they meet a former patient of mine, or they have a little time to think about it, then if they're still having symptoms, they've always said, oh, yeah, I think I'm ready. And sometimes it just takes people a little bit of time to process. There's
Yeah.
not usually an emergency for Chiari, which is good. So anyone that tells you, you have Chiari, we have to do surgery tomorrow, that there's just really not an emergency for taking care of Chiari. There's some patients have Chiari and hydrocephalus, and the hydrocephalus may need to be treated emergently, but that is rare. And typically for patients with Chiari, there's no emergency at all. And so you can be thoughtful about the process.
About how I genuinely don't know this. About how long would you be able to wait before there are some repercussions down the line?
Great question. So it varies. So in my experience, I've seen someone develop a syrinx, a couple years later, and then there's an anecdotal story of a child going on a roller coaster and developing a syrinx just from going on a roller coaster. And so, but the child was having headaches beforehand, so it was a symptomatic Chiari without a syrinx, and then it just became a symptomatic Chiari with syrinx. That being said, I've had many families where the child has Chiari but is asymptomatic, not having symptoms, and they go on roller coasters and they play tackle football and they don't develop any syrinx or problems. And so I think it's all predicated on the symptom.
Mhm.
And so
Yeah.
if you have symptoms, and if the symptoms keep going on for too long, I do think that things can get worse.
Yeah, absolutely. I'm just going to call this out. Someone said, "Thank you for remembering the child's opinion matters and to treat all kids as you would your own." So I just wanted to say
Oh, oh, that means a lot to me. I take that to heart. That's how I treat all my families.
Yeah. And then this is a good question to end on because I like to tie it back in. So do you see just pediatrics? I know you mentioned you will see some young adults in their 20s, but are they previous pediatric patients, or are you willing to see some young adults? And then I guess in that case, how can people get in touch with you?
Oh, great. So, well, I'm at Texas Children's Hospital and Baylor College of Medicine, and so my information's on the web, and so it's easy to get a hold of me that way. And from the standpoint of taking care of older patients, so in my previous practice, I took care of adult and pediatric patients just because I was at a hospital that could do both. And at Texas Children's, I am sticking to more pediatric and young adult just because of the hospital, but may get privileges at the adult hospital down the road. I haven't done that yet, so Um, but at this point, it's mostly pediatric and young adult. Although I'm very engaged with advocacy and do have partners at Baylor College of Medicine who are excellent taking care of patients with Chiari.
Awesome. Yes. Thank
So,
you. And
uh,
thanks everyone for
yeah.
joining.
Oh,
Um,
Caitlin, this was a lot of fun. It was good to talk about Chiari. I mean, I could talk all day. So,
anytime you want. But thanks everyone. And thank you, Dr. Bauer, for doing this with us. It's been awesome.